Carpal tunnel syndrome by Ryan Howard and Alex Wilson. We will begin with an introduction to the carpal tunnel. The carpal tunnel is an anatomical location in the wrist. The floor is formed by the palmar radiocarpal ligament and palmar ligament complex. The roof is the flexor retinaculum, the radial side is the trapezium, and the ulnar side is the hook of the hamate. There are 10 structures that pass through the carpal tunnel, most notably the median nerve, which divides into motor and sensory branches in the tunnel. This is a tightly packed space, and any change occurring in the structures within may lead to carpal tunnel syndrome. In most cases, carpal tunnel syndrome is caused by increased pressure on the median nerve. An increase in pressure can result from enlargement of internal structures or reduced circumference of the carpal tunnel. This is a schematic of the carpal tunnel, and as you can see, it is a very tight space. Any pathologies of the surrounding structures depicted may lead to compression or irritation of the median nerve, and therefore carpal tunnel syndrome. Carpal tunnel syndrome is estimated to occur in 3.8% of the general population, and accounts for 90% of all entrapment neuropathies. 1 out of 5 patients who complain of symptoms of pain, numbness, and tingling in the hands will be diagnosed with carpal tunnel syndrome. It is more common in females and in the age range of 40 to 60 years old. Currently, there is no consensus on the gold standard for the diagnosis of carpal tunnel syndrome. Graham found in 2006 that electrophysiological data alone cannot be taken as reliable evidence of the diagnosis of carpal tunnel syndrome. A systematic review conducted by the American Academy of Orthopedic Surgeons found that no one test is better than another. However, nerve conduction studies are in fact recognized as the diagnostic standard, as found by Vieira in 2003. There is also a clinical prediction rule designed to aid in the diagnosis of carpal tunnel syndrome. The combination of the subjective history, physical examination, special tests, and nerve conduction tests can be used to develop a sound and evidence-based diagnosis. The signs and symptoms of carpal tunnel syndrome include numbness or feeling as though the hand is swollen, with no actual swelling present. There can be a tingling sensation in the wrist and hand. There can be wrist pain that may or may not radiate to the shoulder. There can be hand stiffness in the morning. If carpal tunnel syndrome has been affecting the patient for some time, atrophy of the thenar eminence may be noted, consisting of the abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and the first and second lumbricals. The symptoms may be brought on by repeated hand or wrist movements. Lastly, it should be known that shaking or flicking of the hand will likely stop the pain or symptoms if they are due to carpal tunnel syndrome. This is a diagram of the volar surface of the hand, depicting the muscles of the thenar eminence that may atrophy when carpal tunnel syndrome is present.
The following tests may be positive with carpal tunnel syndrome: Tinel's test, Phelan's test, reverse Phelan's test, carpal compression test, and carpal shake test. Other clinical findings may include atrophy of the thenar eminence, a wrist ratio greater than 0.67, which is the anterior to posterior diameter divided by the medial to lateral width of the wrist. Decreased sensation, particularly over the volar surface of the first 3.5 digits. Impaired myotomes, including wrist flexion of the C7 nerve root, and finger flexion and thumb flexion, abduction, and opposition of the C8 nerve root. It is possible that not all of these tests will be positive. These pictures demonstrate some of the tests commonly used to assess for carpal tunnel syndrome. In 2005, Weiner et al. Developed the following clinical prediction rule for carpal tunnel syndrome. Criteria include age greater than 45, shaking hands to relieve symptoms, wrist ratio greater than 0.67, symptom severity scale greater than 1.9, and diminished sensation in median sensory field 1, the thumb. When 4 out of 5 of the above are present, the positive likelihood ratio is 4.6. When 5 out of 5 of the above are present, the positive likelihood ratio increases to 18.3, which is statistically significant. Some common interventions for carpal tunnel syndrome include patient education, splinting, therapeutic exercises including nerve and tendon gliding exercises, stretching, ultrasound, posture and ergonomic corrections, yoga, and carpal bone mobilizations. O'Connor et al. Found that hand braces significantly improve symptoms after 4 weeks. Patients undergoing ultrasound experienced significant symptom improvement after 7 weeks, which was maintained at 6 months. Patients participating in yoga experienced significantly reduced pain after 8 weeks. Patients receiving carpal bone mobilizations experienced significant improvement in symptoms after 3 weeks. Trials of magnet therapy, laser acupuncture, and chiropractic care did not demonstrate symptom benefit when compared to placebo or control. Many patients respond well to conservative treatment. The majority of patients recover completely. Splinting, nerve gliding exercises, and activity modification can control symptoms sufficiently to prevent surgery with mild to moderate carpal tunnel syndrome. In cases of failed conservative management, surgery is typically the next step. Many patients who do go on to have surgery experience reduction in their symptoms. Outcome measures used in carpal tunnel syndrome include questionnaires such as the Upper Extremity Functional Scale, the Michigan Hand Outcomes Questionnaire, Patient Evaluation Measure, Disability of Arm, Shoulder, and Hand Questionnaire, and most commonly, the Boston Carpal Tunnel Syndrome Questionnaire. Functional measurements include grip strength, pinch strength, and manual muscle testing of wrist flexion, finger flexion, thumb flexion, and thumb opposition. We hope you enjoyed our presentation. Thank you.